Ethical Perspectives on the News is produced by the Interreligious Council of Lynn County, which is solely responsible for its content. The views and opinions expressed on this program do not necessarily reflect those of the staff and management of KCRG TV9.
Good morning. Welcome to this week's edition of Ethical Perspectives on the News. My name is Craig VanSandt. I teach at the University of Northern Iowa and hold the David W. Wilson Chair in Business Ethics there. Our topic this morning is the ethics of drug pricing. To discuss that topic, we have a panel here that I think you will find very informative today. With us this morning is Ben Urick, a pharmacist and PhD student at the University of Iowa. Welcome to the show, Ben.
Thank you.
Our second panelist is Dr. Chirantan Ghosh, who is a doctor, a medical doctor, and founder of the Ghosh Center for Oncology and Hematology. Dr. Ghosh, thank you for being with us.
Sure.
And we're also very happy to have John Rosmann with us, who is the executive director of the Iowa Prescription Drug Corporation. John, thank you for coming over from Des Moines.
Thanks for the opportunity.
Well, as I said, our topic today is the ethics of drug pricing. There has been no shortage of news this fall about price increases with prescription drugs. If you read the news, you see that prices, or at least it seems to be, that prices are going up very rapidly. Ben, I'd like to start off the questions with you as a PhD student. Is the popular press giving us an accurate picture? Are prices going up this rapidly?
You know, I would say it depends on the medications you look at. If we talk about brand name pharmaceuticals, the answer is yes. Certainly things like Sovaldi, made by Gilead Pharmaceuticals for hepatitis C, coming out at $86,000 is an incredible price to pay for a therapy like that. You know, I'm sure many of the viewers have heard about Daraprim that was purchased by Turing Pharmaceuticals, where they increased the price 5,000%. Now, I mean, those are extreme cases, but I think it does show something a bit larger about the state of brand name pharmaceuticals. Now, if we talk about the cost of medications in society as a share of total healthcare spending, pharmaceuticals have doubled since the early 90s. We went from about 5% of all healthcare spending in the early 90s being spent in pharmaceuticals to about 10% today. And a lot of that increase is increased prices of very expensive brand name products. Now, if we talk about generic products, which are actually about 85 to 95% of all products dispensed in the United States, those products have generally stayed about even or even a little bit down. But even within that category, there are some generic drugs that have had extremely high price increases as well. So definitely within brand name drugs, big price increases. Generic drugs, most of them not, but a few of them you also see price increases as well.
Okay. The other question that I would like any of you to address is the question of drug prices in the U.S. versus in foreign countries. It's my understanding that we pay significantly more here than in other countries. Is that true?
That is true. 50 to 80% more we pay here than in Europe. Okay.
And why is that?
You know, I don't know. I think it's a multifactorial. I think anytime we talk about the drug pricing, the pharmaceutical company will say what they say, that it takes time, effort, cost, and money to produce a drug and so on and so forth. I think story is more than that. I'm going to give you an example. The science, the molecular biologists, create a scientific trump curing chronic myelogenous leukemia with a targeted drug that's called imatinib or Gleevec. It was marketed in 2001, and I remember I was in the clinical trial, $28,000. We thought that's too pricey. We have heard and we supported the concept that they have to recover the cost. Today, same drug, more people are using it. You know, chronic use is more business. Now, like if you take an antibiotic, you take for 10 days. But if you take antibiotic year after year, year after year, it's a different profit. We are selling this drug to $98,000. So please, I want to hear what research has been done more for a drug that was discovered in 2001. And then, we feel that competition, if you have similar drugs, the price should go down. We have 5 similar drugs. The price of the other drug has gone up to $130,000. Wow. So we are creating a lot of new drugs, a lot of good treatment, but we are pricing it out, the patient's care. Let me tell you, the published study shows that the outcome of chronic myelogenous leukemia in United States is poor than in European country. We have created a structural disincentive for non-compliance. People are not taking the drugs because they cannot afford to take the drugs. If you have a $100,000 drug and we have insurance, that's a vague word. Most of the drug is coming as an oral. We need a prescription benefit. Many patients do not have prescription benefit, and when they have 20% copay. So if you have a $100,000 drug, and if your copay is $20,000, and average income in United States is $52,000, so how a person can come up with $20,000? They are not taking it. Breast cancer. We cure breast cancer by giving drug to block the estrogen receptor, tamoxifen or aromatase inhibitor. Patients are not taking it. So all the scientific trump that we are doing it, we are not able to deliver that because of the structural pricing. I have some number. Valiant increased the price of sodium nitroprusside on next day of they acquired the drug by 625%. Isopril, the drug they acquired, in next day, it went up by 820%. Penicillamine, a drug that was used for a long time, I read in my medical school, went up by 2,949% in a day.
If I might interrupt you there, I gather that you're very concerned about this for your patient's sake, and I'll ask you to talk some about what your center does in a minute. But John, I'd like to get you in here as well. I wonder if you could tell us a little bit about what IDPC does and your interest in drug pricing.
Yeah, absolutely. Well, the whole mission of our organization is quite simple, and it's simply to connect low-income, uninsured, or underinsured patients with access to free and low-cost medications. So much of what we're talking about today is simply the issue that we're trying to address. We're a safety net provider. So we work to try and provide access to affordable or free medications. So we have developed a model where we are actually, in essence, recycling medications, taking previously dispensed medications, having those medications inspected by a pharmacist, and then we provide them to pharmacies or to clinics to dispense to patients at no cost. So we're very familiar with the issue, and it's a main reason why there's such a dire need for our programs, but unfortunately, we don't have the solution. We're just trying to fill the gaps best we can.
Okay, well, coming back to what you were talking about, it sounds like we're paying significantly more for drugs in this country, and the medical outcomes aren't any better or may even be worse. Is that accurate, Ben?
Yeah, so actually there was a great article that came out in the Wall Street Journal on December 1st that looked at how much we spend in the United States for these sterile injectable drugs, like a lot of the ones that you'd use in your practice. Compared the prices here in the U.S. to prices in England and in Norway. And what they found is that for 37 out of these 40 drugs, we spend more than Norway does. And for 39 out of these 40 drugs, we spend more than England does. Now, these are the exact same medicines that they're getting in England, that they're getting in Norway, but we're paying a lot more here in the United States. Just one specific example from this. Rituximab, very commonly used in cancer therapy, costs $3,500 a dose here in the United States. Norway, $1,500. It's a $2,000 difference for a very common drug. So you do see that we spend a lot more in the United States on brand name medicines. Now, you can't really say that we spend a lot more in the United States on generic medicines. We have great laws for generic medicines that allow for solid competition within the generic market that does bring down prices and actually, economics work as you would expect them to, where you bring more competitors into a market and then prices for those products fall. But as we were talking about with brand name pharmaceuticals, the economics, the kind of that basic idea of a firm coming in and lowering the price doesn't work. If you see Gleevec, for example, whenever you have a competitor enter into the market at a little bit higher price, the manufacturer for Gleevec understands that they can raise the price on Gleevec a little bit because there's a new sort of price that the market will bear. And so whenever you see, oftentimes when you see new brand name pharmaceuticals come in, they come at a little bit higher price, rising tide raises all ships, and you see this increase in price over time.
Well, my understanding, and again, I don't want to go too far down this rabbit hole, but my understanding is even some of the drugs that are going off of their patent, which then you would normally think would allow generic drugs to be produced, the companies that own those patented drugs do what they can to keep other manufacturers from producing generics. Am I right on that?
Yes. Now, this gets into FDA law, and we don't have the time this morning to right.
And none of us are lawyers.
Right, including me. But you're right. So these are called pay-for-delay settlements, and it's something that, if you look it up online, you can see pay-for-delay settlements. What happens is the first generic entry to the market oftentimes has 6 months of exclusivity, if it's the first drug that comes into the market. Now, they can forego that 6 months exclusivity in exchange for some sort of large payment from a brand name pharmaceutical manufacturer. Now, the FDA has determined that there were a couple of lawsuits that were surrounding this, and what we've kind of found out now is that it's not necessarily strictly illegal for brand name companies to offer settlements to generic companies to delay their product entry into the market. They have a pretty high level of scrutiny for these, but they're still technically allowed. Now, there's an idea that since you're going 6 additional months without any sort of generic competition, that you do end up increasing prices for anybody who would purchase that drug. And that is true to a large extent. So these pay-for-delay settlements, they have some impact, but I would say that that's not anything that makes a big impact on the amount of money that we spend in pharmaceuticals in the United States.
Okay.
Yeah.
But I think conceptually the law needs to be changed, because when a pharmaceutical company manufactures a drug, there is a life of the patent. It is a routine thing to delay, push back the generic products by lawsuits, this, that, and that takes 4 or 5 years. So that needs to be prevented. And also the company goes to the court and appeals for extension of that patent. I think the law needs to be defined upfront, that this is the duration of the time, you have the patent, you cannot come back and extend that, and you cannot push back the generic products. So there is a disincentive for the generic product manufacturer to manufacture those drugs because they know that they might not be able to sell it for years. The law needs to be changed. And I think the only way it will be changed is that if we have a patient's advocacy.
Okay.
And I'll tell you that we have an experience in the United States. We have done it with the AIDS movement. The AIDS movement, the FDA changed the law. The way the business was done, the pharmaceutical company agreed on that. They produced 35 drugs in 10, 15 years, and they kept the price down to $18,000, and the life has been prolonged. So I think we have an example when the patients get involved in it, the community gets involved in it, things do change.
Okay. To put that in perspective, this was, if I remember right, the late 1980s, early 1990s? Am I in the right
1988,
time frame?
right.
So, not that any of us are political experts, but my take is that the chance of getting government to make the kinds of changes you're talking about with the AIDS issue is much less today than it was 20 years ago.
So I think we need to go back the history. These were young men who shut down the FDA for a day, closed the Wall Street for 2 days. They were young, they were there, they advocate, they were their own advocate. The government is not going to change unless we make it change. So there is a movement that is going on from our part. This is change.org. We want to submit 1 million signature to the Congress, Senate, and that this needs to be addressed. Mm-hmm. In a discussion way, we are rationing the care. We are depriving the care in the back door. Let's talk upfront and make a change. So that was the difference, is the AIDS advocates, the patient who are on the street. Now, we have cancer advocacy group. Unfortunately, most of them are funded by the pharmaceutical companies.
Right.
John, does your organization get involved in patient advocacy?
Yeah, absolutely. We provide most of our services directly to pharmacies or medical providers, but on a daily basis, we receive a number of calls from patients that are dealing with the struggles of accessing medications. And I think it's important to note that the safety net patient, at least in Iowa, has changed very much over the years, because historically we've thought of a safety net patient as an individual that is low income, uninsured. Iowa has been fortunate to take part in Medicaid expansion, so we have an additional 99,000 persons that are now covered. However, we also have those people that are in the category from 138 up to 200% of the federal poverty level, where technically many of these patients are insured, but for example, that insured patient could have insurance through a bronze level plan, and that bronze level plan will require an individual, for example, 200% of federal poverty level, that would be $28,000 approximately. That person would have a $6,300 deductible before any medication assistance or medical coverage is provided. So I think it's important to note that although we have more insured patients in the state, the services are still required from the underinsured patients, and something needs to be done to address that as well.
Okay. And as we were talking before the show, you indicated that the organization that you represent is somewhat unique in the United States.
Our organization is another good example of how Iowa has been somewhat of an innovator on the issue. Our organization was established through a partnership with nonprofit and public. So we were initiated by Senator Harkin and then Governor Vilsack, and our mission is simply to provide access to free and low-cost medications. We do that through a variety of funding mechanisms, many of which are contracting with the Department of Public Health or with the Attorney General's office to implement these programs. And we're fortunate enough that we have legislative leaders that have valued access to medications in our state, and we have now developed the largest drug donation repository in the country. So our state serves as a model for how medication or medication waste, existing medications within the healthcare system, particularly long-term care, how those medications can be recovered, inspected, and repurposed for patients that cannot afford their medications.
Well, thank you for bringing a bit of good news to this show.
Just one question I have,
Yes.
and thanks for doing this. But the question I have, say somebody needs medicine like Gleevec we talked about in cancer care. That's a day after day, months after months. Do you think that your organization can fulfill that need?
Well, that is a great question. And 95% of our medications are coming from long-term care settings, so coming from nursing homes. So many of those medications are going to be maintenance medications, hypertension, diabetes. But one of our areas of focus is to try and bring more specialty medications into the donation program. So we're just starting an initiative to provide outreach to the oncology centers and the cancer centers to bring those medications in. It's not an ideal situation, because anytime you're working with donated items, you have no way of controlling your inventory. But for some patients, we can fill gaps in access, and for a family where an individual may have passed away, we can provide a meaningful way for that family to provide a positive outcome where a patient
I think that's a great effort, but that does not answer the biggest problem that we are facing.
Right.
Now, we are making great inroad in the cancer care. The melanoma, all the new immunotherapy, checkpoint inhibitor, fantastic outcome. For example, in melanoma, the two drugs together is going to cost $159,000 per year. And if you have to treat all the melanoma to provide the best care that we have defined, it is going to cost $281 billion per year. So right there is the issue. In 2014, the world was spending $100 billion on the cancer drugs. So those kind of differences we need to solve, and we need to solve by discussing openly, honestly, because I don't think any drug is a good drug if the patient cannot take it. That's not a drug to me.
Well, I appreciate that, and I'd like to change gears a little bit with you all now. We've seen, just from our discussion, that there is a crying need for these drugs. We've seen that there is a very strong profit motive from the companies producing them. How do we meet in the middle? And I think part of my question that I want to get at there is health care a right that citizens have, or is it a privilege that people should pay for? Ben?
Healthcare is not a constitutional right in the United States. That's what the courts have said so far. The only people in the United States who have a right to receive healthcare are prisoners, because it's considered cruel and unusual punishment if they are not given healthcare. Now, do I think that healthcare should be a right? That is how I tend to think. But that is something that I don't think would actually happen in the current political climate, right? So what we're left with is solutions that really, if we want to talk about reducing costs of medications for society, involve more intervention from the federal government. Those are the solutions to providing reasonable access to health care that other industrialized nations have come up with, but we in the U.S. have been very resistant to this. One thing that is kind of a low-hanging fruit is allowing Medicare to negotiate for the same kinds of rebates that are negotiated for in the Medicaid program. So the Medicaid program saves about 50% of all of their drug costs because they have federally mandated rebates. Medicare, when it was set up, was actually barred from negotiating with drug companies.
Right.
Some backroom dealing with Billy Towson, who ended up being the president of Pharma afterwards. Apologies to Pharma if they're watching this presentation. Now, that can save substantial amount of money for the federal government when it comes to pharmaceuticals, and would likely lower, to an extent, the amount of money that we in the U.S. pay for drugs. So at the very least, for some Medicare patients, I think it can make a big difference for their care. Yeah.
That should be done, because most of cancer patient is Medicare populations. They're not young, so we are denying the care to our citizen, and it has becoming a care of the privileges. I'm going to give you an example. President Obama says that we are providing the health care and you can pick and choose. I know patient who has money, they get the platinum product, they get the free care. I know patient who was good and tried to get a product that she can afford, bronze. She has copay. She does not know to get the care. She cannot pay for it. So that we are providing the care to everyone is wrong. We are providing the care to the privileges, and actually the person who can pay the bigger premium, his care or her care is getting subsidized by denying care to the other folks.
Now, we're here talking about high drug prices in the United States, and the Wall Street Journal article was talking about a driving factor for high drug costs in the U.S. is all the R&D. So how do we balance focusing on drug costs with the United States when the U.S. bears the majority of the R&D cost? I mean, shouldn't we be talking about the larger issue of drug costs including partnerships with other countries if we're going to try and come up with a solution to drive down costs in the U.S.
Right, and I think that, talking about spreading out the R&D burden more globally, right, because everybody benefits from the amount of money that we as U.S. citizens spend on our pharmaceuticals. But also, I would question R&D as the sole justification for the amount of money that we're spending on these pharmaceuticals. 9 out of the top 10 largest manufacturers spend more on marketing than they do on R&D. And if you look at the S&P 500 list, pharma companies have a 17% profit margin. S&P average is only 6%. So they use R&D as a justification for the price that they charge, but I really have a hard time buying that.
Well, so now is the time in the program to talk about solutions. Mm-hmm. What do we do to make drug prices in the U.S. more fair?
Go ahead. No, you go ahead.
So one is negotiating through Medicare. That would help at least for Medicare patients. Market-driven solutions include funding the FDA better, or at least allowing them to increase their fees to generic manufacturers, so they can move generic products through the pipeline a little bit faster and create more competition within the generic space. It's also very important for us to develop an effective biosimilar pathway so that we can get competition for the very expensive biologic products that are causing a lot of the increase in spending. If you look on Hillary Clinton and Bernie Sanders' websites, they have full lists of policy options they think are viable for reducing drug costs. Some more than others. Bernie wants to go up to Canada to bring down medicines as part of reimportation. I don't think that would work. And Hillary Clinton's idea is to set a maximum out-of-pocket maximum at $250 per month for everybody in the United States on pharmaceuticals.
Right.
So it means you could not spend more than $250 a month out of your own pocket on pharmaceuticals. It's an interesting idea. I don't think it would pass politically, and I wonder if that wouldn't actually increase the total amount of money that we spend on pharmaceuticals in the United States, because it would reduce co-payments as a mechanism for controlling drug spending.
Okay. I'm really sorry that I didn't get you all involved in the solutions problem, but we're about out of time. So I'd like to ask you at this point, what do we need to leave our viewers with? What information? Dr. Ghosh?
We are talking about the drug pricing, but we need to talk as a whole. For example, I'm an oncologist. Studies have shown that after you cure Hodgkin's lymphoma, doing repeated CT scan costs $591,000 to save one life. We should not be doing that. So I think the national organizations, NCCN and other, they need to step in and guide us, because that's the way to help the insurance and also pharma too. So I think we have a global responsibilities, if you have ductal carcinoma in situ stage 0, sentinel lymph node sampling should not be done, but it's being done. So we are wasting resources in other places. The new drugs are going to come, it's going to be expensive, our closet is full, so we need to get rid of the old stuff, like doing the things that we did before.
Great. Thank you. John?
Well, I think we need to focus on things that we can have impact on now, because some of our solutions could take decades. But we can do a better job of recouping costs within our own healthcare systems and utilizing models to help recycle or repurpose medications within the system.
Thank you all very much for your help. On behalf of the Interreligious Council of Linn County, I'd like to thank all of you. I'd like to thank you for watching. Have a great week.